We were studying about autoimmune hepatitis, and now we'll proceed further. So here we have a 67 years old woman complaining of intermittent difficulty in swallowing. She had a stroke 6 months ago, shortly after she started losing weight. She has had three chest infections in the span of 6 months. Medical team has decided that she would require a procedure to address her feeding issue. What is the most appropriate procedure to perform for long-term feeding in this case? So here we have to study about artificial feeding, enteral feeding, and percutaneous endoscopic gastrostomy. Uh, let's first study about artificial feeding and enteral feeding. The term artificial feeding includes enteral nutrition and parenteral nutrition. Enteral feeding is where nutrition is delivered to the GIT, that is gastrointestinal tract, by a tube, whereas parenteral nutrition is where nutrition is given intravenously when a patient cannot absorb nutrition through their gastrointestinal tract. So, artificial feeding includes enteral nutrition and parenteral nutrition. Enteral nutrition or feeding is where nutrition is delivered to the gastrointestinal tract by a tube, whereas parenteral nutrition is where nutrition is given intravenously when a patient cannot absorb nutrition through GIT. We will focus more on enteral feeding as this is more commonly asked. Now, enteral feeding is considered when a patient has significant dysphagia. Common uses are in patients who have strokes, motor neuron disease, or Parkinson's disease. So, enteral feeding So the three most common methods in enteral feeding, the common uses we already know, it is strokes, patients of stroke, motor neuron disease, and Parkinson's disease. Three most common methods of enteral feeding are nasogastric tube, that is NG tube, percutaneous endoscopic gastrostomy, and radiologically inserted gastrostomy. Three methods: NG tube, nasogastric tube, percutaneous endoscopic gastrostomy, and radiologically inserted gastrostomy. Now, NG tube. NG tube is a fine bore tube and it is the preferred method for short-term feeding. Example, a patient who just had stroke cannot swallow. Over the next few weeks, his swallowing could improve, and therefore we would want an enteral feeding that is quick, inexpensive, and easily reversed. Now we'll talk about PEG, that is percutaneous endoscopic gastrostomy. Firstly, the patient has to be fit enough to undergo sedation. For this, the procedure is more complex than inserting an NG tube and it is done by general surgeons. A flexible feeding tube is placed through the abdominal wall into the stomach directly so as to allow feeding directly into the gastrointestinal tract. So, for this, the patient has to be fit enough to undergo sedation. Procedure is more complex Now, example, a patient who had a stroke cannot swallow later had an NG tube inserted in the first few days after a stroke for enteral feeding. A few weeks down the road, example, more than 4 weeks, he is still unable to swallow even fluids. At this point, there would be a discussion with him and his family if percutaneous endoscopic gastrostomy would be a suitable forward for feeding. Or example two, a patient with cancer of head, neck, or esophageal cancer where mass is obstructing feeding through the oral route. One would consider percutaneous endoscopic gastrostomy. Now, there are always ethical issues with percutaneous endoscopic gastrostomies, which we may see in the exam. It is common to find these issues with obtaining approval from the next of kin for a non competent patient. It is also imperative that we understand that percutaneous endoscopic gastrostomy for patients who have seriously impaired cognitive function who cannot swallow may not be the most ethical decision, as there may not be a potential for improving quality of life. There should be a decision made by a medical team in multidisciplinary meeting should there be absent advance directive or legal power of attorney for health. So there are always some ethical issues uh, involved with percutaneous endoscopic gastrostomy. That is obtaining approval from the next of kin for a non-competent patient. Also that for patients who have seriously impaired cognitive functions, who cannot swallow, PEG may not be the most ethical decision. As there may not be a potential as there may not be a potential for improving quality of life. So, done by multidisciplinary team, multidisciplinary meeting by medical team. Now, radiologically inserted gastrostomy, RIG, or radiologically inserted gastrostomy. Now, these rigs also have similar complications to PEGs. It is considered when a PEG is unsuitable. For example, if gastroscopy is difficult, pharyngeal pouch is there. Remember, pharyngeal uh, percutaneous endoscopic gastrostomy use gastroscopies. Then a rig would be done, since rigs are done using X-ray guidance after barium is placed inside the stomach. So it is considered when PEG is unsuitable. For example, if gastroscopy is difficult, like in pharyngeal pouch, then radiologically inserted gastroscopy would be done using X-ray guidance after barium is placed inside the stomach. Because we know percutaneous endoscopic gastrostomy uses gastroscopy. Because endoscopy is used, it is done by endoscopy only, so gastroscopy or endoscopy is done by uses gastroscopies. So artificial feeding and enteral feeding. Artificial feeding includes enteral nutrition, parenteral nutrition. Enteral nutrition or feeding, Enteral nutrition or feeding is where nutrition is delivered to the GIT by a tube. Parenteral nutrition is where nutrition is given intravenously when a patient cannot absorb nutrition through GIT. Enteral feeding is considered when a patient has significant dysphagia. And common uses are in patients of stroke, motor neuron disease, Parkinson's disease. Three most common methods are nasogastric tube. Three most common methods of enteral feeding are nasogastric tube, that is NG tube, percutaneous endoscopic gastrostomy, PEG, radiologically inserted gastrostomy. Three methods. NG tube is a fine bore tube which is a preferred method for short-term feeding. It is a quick, inexpensive and easily reversible method used for short-term feeding. Now, second method that is PEG or percutaneous endoscopic gastrostomy. For this, the patient has to be fit enough to undergo sedation because this is a surgical procedure done which is more complex than placing an NG tube, and it is done by general surgeon. A flexible feeding tube is placed through the anterior abdominal wall. A flexible feeding tube is placed through the abdominal wall into the stomach directly so as to allow feeding directly into the GIT, directly into the gastrointestinal tract. Example, in a patient with NG tube inserted initially for a few weeks, if even after a few weeks, like for more than 4 weeks, the patient is still unable to swallow fluids, then PEG or percutaneous endoscopic gastrostomy would be suitable. Or a patient with carcinoma of head and neck or esophageal cancer where some mass is obstructing the feeding through oral route, there also PEG can be considered. In both these cases, in a patient having NG tube inserted initially, if the patient is still unable to swallow even after a few weeks, like 4 weeks, let's say, then percutaneous endoscopic gastrostomy can be done. It can be considered. Or patient with carcinoma of head and neck or esophageal cancer where mass is obstructing the feeding through oral route, there also it can be considered. Now there are always ethical issues involved with PEG. These are obtaining approval from the next of kin for a non-competent patient, and we also have to consider that for patients who have seriously impaired cognitive functions who cannot swallow, PEG may not be the most ethical decision, and there may not be so much potential for improving quality of life. There may not be any scope of improving quality of life of the patient. So it is done by a multidisciplinary meeting by a medical team. And last one is radiologically inserted gastrostomy. It is considered when PEG is unsuitable. For example, in case of pharyngeal pouch where gastroscopy is difficult to do, therefore in such cases rig would be done using X-ray guidance after barium is placed inside the stomach, because in PEG we have to do endoscopy or gastroscopy. So percutaneous endoscopic gastrostomy or PEG is a procedure in which a flexible feeding tube is placed through abdominal wall into the stomach so as to allow nutrition and fluids to be administered directly into the GI tract, bypassing the oral route. Bypassing the oral route. Example of patients which would benefit from these procedures include dysphagia from stroke or motor neuron disease, cancer of head and neck. Initially, for short-term feeding, we would give NG tube. Then later on, if they are still unable to swallow any fluids, we can consider giving feeding through uh, percutaneous endoscopic gastrostomy. Or in patients of carcinoma of head and neck, esophageal cancer, patient of stroke, motor neuron disease, in them also we where there is a mass obstructing the oral pathway, where there is a mass obstructing the feeding through the oral pathway or oral route, there we can consider PEG. Now let's move further now. Now, a 22-year-old female comes to GP surgery with complaints of diarrhea for several months, which have been worsening over the past week. She says that she opens her bowels in excess of 5 times in a day for the past week. She also has recurrent bloating that makes her very uncomfortable with right sided abdominal pain. The pain is mild, does not interfere with her daily activities, but she is quite concerned about the blood in stool, which she noticed this morning. She leads a busy lifestyle, holding down two jobs, has had some recent weight loss, which she attributes to stress and poor nutrition. She smokes a pack of cigarettes a day to deal with her stress. There is no significant past medical history. On physical examination, the patient appears pale. Her BMI is 17. On further oral examination, she is noted to have multiple ulcers in her mouth. Abdominal examination reveals distended abdomen, tenderness, or right lower quadrant with no palpable mass. What is the single most likely cause of her condition? Now, this is a case of Crohn's disease, and now we have to study about certain things about Crohn's disease management. First of all, this patient is suffering from Crohn's disease. In this scenario, we have multiple clues which are pointing towards Crohn's disease, such as diarrhea with the location of abdominal pain. The patient is having diarrhea, and abdominal pain is in right lower quadrant. Right sided abdominal pain is there. The common site of the pain in Crohn's disease is lower right side of the abdomen. It is due to the involvement of small intestine, that is ileum. So the commonest site of pain in Crohn's disease is right lower quadrant of abdomen due to the involvement of small intestine or ileum. Other common features can be weight loss, which is more significant than ulcerative colitis, and there can be mouth ulcers as well, aphthous ulcers. Another subtle hint is a history of smoking. History of smoking is also significant here. So for Crohn's disease, certain hints can be right lower quadrant pain is there, weight loss is there, and apart from that, history of smoking. Smoking increases the risk of developing Crohn's disease by about 3 to 4 times. 3 to 4 times risk, more risk. While ulcerative colitis can also present as chronic diarrhea, but it more often involves the other part of the colon, that is left-sided colitis. In ulcerative colitis, we will have pain towards the left side, not right side. In ulcerative colitis can present as chronic diarrhea, but it is more often involving the other part of the colon, that is left-sided colitis. So it's about that. Here we have right-sided, right lower quadrant abdominal pain. History of smoking is there, which increases the risk of Crohn's disease by about 3 to 4 times. Then diarrhea is there, mouth ulcers are there, weight loss is there. It is not ulcerative colitis because the pain is not on the left side. Now, in celiac disease, diarrhea is mainly due to malabsorption, which leads to abnormally high levels of fat in stool termed as steatorrhea, which is not the case in this patient. In celiac disease, diarrhea is due to malabsorption, leading to abnormally high levels of fat in stools termed as steatorrhea. Now, colon cancer is the last thing which you should be thinking because of the age group of the patient. And colon medications are not the right option as there is no significant past medical history in this patient. So, ulcerative colitis is a form of inflammatory bowel disease which is characterized by inflammation of colonic mucosa and submucosa. The inflammation typically begins at the rectum and it spreads proximally, largely affecting the colon alone. The disease has a relapsing and remitting course with the etiology still not being fully understood. Management aims to induce and maintain remission using various medication and entails colectomy in refractory cases. So it is characterized by inflammation of colonic mucosa and submucosa and it begins at the rectum and it spreads proximally, mainly affecting the colon alone, affecting mucosa and submucosa. Mucosa and submucosa of mainly colon involved begins at rectum and spreads proximally. Celiac disease is a systemic autoimmune condition where antibodies to the gluten peptide gliadin trigger immune activation into the small intestine. The disease is characterized by villus atrophy, crypt hyperplasia, epithelial lymphocyte invasion in the small intestine. Management involves a lifetime of following a strict gluten-free diet. Celiac disease, auto systemic autoimmune condition where antibodies to gluten peptide gliadin triggers antibodies to autoimmune condition. Antibodies to gluten peptide gliadin trigger immune activation in small intestine. Immune activation in small intestine and management involves gluten-free diet. So antibodies to gluten peptide gliadin. So antibodies to gluten peptide gliadin, they trigger immune activation in the small intestine, which leads to a systemic autoimmune condition called celiac disease, and there is due to which there is villus atrophy, crypt hyperplasia, epithelial lymphocyte invasion is affecting the small intestine. So management involves lifetime of following a strict gluten-free diet. Crohn's disease management. Now, Crohn's disease management is divided into inducing remission and maintaining remission. Inducing remission is by corticosteroids. If corticosteroids are contraindicated, then we use budesonide or aminosalicylate such as mesalazine. Mild to moderate disease is there. So C for Crohn's, C for corticosteroids as the first line to induce remission. If they are contraindicated, use budesonide or aminosalicylate such as mesalazine. Maintaining remission, the medication used for maintaining remission are MAM, that is methotrexate, azathioprine, and mercaptopurine. So, inducing remission and maintaining remission. Inducing remission by corticosteroids. If corticosteroids contraindicated, use budesonide uh, or aminosalicylates such as mesalazine. So, Crohn's, C for Crohn's, C for corticosteroids as first line to induce remission. Maintaining remission is done by MAM, that is methotrexate, aminosalic, methotrexate, azathioprine, and mercaptopurine. Methotrexate, azathioprine, and mercaptopurine. And now let's move further. Here, there is a 36-year-old bodybuilder presenting with sudden onset of severe abdominal pain. He was previously fit and well and only suffers from indigestion occasionally. He has been taking ibuprofen for a long-term knee injury. On examination, he has rigid abdomen, lies motionless on the bed, has no bowel sounds. His pulse rate is 115, blood pressure is 160. Single most likely diagnosis in this case. So now we'll study about perforated peptic ulcer here. It's a case of perforated peptic ulcer. So the diagnosis here is perforated peptic ulcer induced by NSAIDs. The sudden onset, rigid abdomen, lying motionless, no bowel sounds are all hints that point towards perforated peptic ulcer. Perforated peptic ulcer. Perforation of a gastric or duodenal ulcer is usually a severe, painful, sudden event. It may occur in those without known peptic ulcer disease as well as those with previously diagnosed problems. However, close questioning may reveal recent symptoms attributed to indigestion. Sudden localized epigastric pain spreading to the remainder of the abdomen, and the pain is worse on coughing or moving, may radiate to the shoulder tip. Perforation of gastric or duodenal ulcer is usually a severely painful sudden event. It can So in examination, first there is sudden localized epigastric pain spreading to whole abdomen. Pain is more on coughing and moving, and it may radiate to the tip of shoulder. And then examination reveals that although the patient is distressed, the patient still prefers to lie still rather than rolling out. And there is absent bowel sounds, shock, and generalized peritonitis and fever. Investigations we have to do are: an erect chest x-ray will demonstrate free gas under the diaphragm. In those cases where the diagnosis is suspected but not proven by x-ray, a contrast CT scan may be helpful. Treatment is by providing IV analgesia, giving an antiemetic like IV metoclopramide 10 mg, resuscitate with IV 0.9% saline, and refer to the surgeon, give IV antibiotics. So, perforated peptic ulcer. So, diagnosis here is perforated peptic ulcer induced by NSAIDs, can be induced by NSAIDs. The sudden onset and rigid abdomen, lying motionless, no bowel sounds, these are all hints which point towards perforated peptic ulcer. Sudden onset, rigid abdomen, lying motionless, no bowel sounds, all are hints pointing towards perforated peptic ulcer. So, perforated peptic ulcer, perforation of a gastric or duodenal ulcer is usually a very painful and sudden event. It is a severely painful sudden event. It may occur in those without known peptic ulcer disease as well as those with previously diagnosed problems. So, they may reveal recent symptoms attributed to indigestion. Now, sudden localized epigastric pain. Sudden localized epigastric pain spreading to the remainder of the abdomen and the pain being worse on cuffing or moving and may radiate to the shoulder tip. Examination reveals that the patient, although distressed, the patient still prefers to lie still. Although distressed, the patient often prefers to lie still rather than rolling about. There are absent bowel sounds, absent bowel sounds, shock, and generalized peritonitis and fever may also develop as time passes. Investigation, an erect chest X-ray, an erect chest X-ray will demonstrate free gas under the diaphragm. Erect chest X-ray can demonstrate free gas under the diaphragm. In those cases where X-ray is not useful, contrast CT scan may be helpful. Treatment: provide IV analgesia, give antiemetics such as IV metoclopramide 10 mg, metoclopramide 10 mg IV, then resuscitate with 0.9% saline. Resuscitate with 0.9% saline IV intravenously, then refer to surgeon, give IV antibiotics. So IV analgesia, antiemetics, IV metoclopramide 10 mg, then resuscitation with IV 0.9% saline, referring to surgeon, and IV antibiotics. So these are the things which should be done here. Now let's move further. A 45-year-old woman is brought to the emergency department having vomited large amounts of blood over the past hour. She had 3 episodes of vomiting at home, one more episode in the ambulance. Her husband reports that the blood was bright red in color. She had been diagnosed with rheumatoid arthritis 6 years ago and is being managed on celecoxib. She was otherwise fit, well, tries to maintain a healthy lifestyle. In addition to regular exercise, she neither consumes alcohol nor smokes. On assessment, she has a heart rate of 130 beats per minute, blood pressure of 70/50. What is the most appropriate next step in managing this patient? So, in this patient, the most appropriate next step in management is IV fluids, that is, intravenous fluids. The patient's complaint of hematemesis is most likely linked to her long-term use of NSAIDs, that is, celecoxib, in the management of rheumatoid arthritis. These NSAIDs are notorious for their propensity to cause gastric ulceration, which likely leads to erosion of a blood vessel. The patient is hemodynamically compromised, provided that she is hypotensive and tachycardic. Therefore, priority in such a case is to bring about hemodynamic stability. So here the hematemesis is linked to long-term use of NSAIDs, which can cause gastric ulceration leading to erosion of a blood vessel. So if patient is hemodynamically compromised and with hypotension and tachycardia, so priority is hemodynamic stability. The immediate or next appropriate step in managing this patient would be to obtain IV access via two large bore IV cannulas and start the patient on intravenous fluids. In the interim, blood grouping cross matching must be performed. If the patient is deteriorating while on IV fluids, O negative blood may be administered. Now, provided this patient is most likely having a gastric ulcer, terlipressin, which is a drug more commonly indicated in the case of esophageal varices, would be the less favorable of the options, along with the insertion of Sangstaken Blakemore tube, which is reserved for uncontrolled varicose bleeding. Endoscopic band ligation, as the name suggests, is used in the ligation of varices, would not be useful in the case of gastric ulceration. So, in this case, drug terlipressin, which is an analog of vasopressin used as a vasoactive drug in the management of hypotension. Terlipressin is an analog of vasopressin used as vasoactive drug in the management of hypotension. It is used commonly to treat bleeding esophageal varices. Works by narrowing the blood vessel so that the blood flow is restricted, which in turn controls the bleeding. Terlipressin analog of vasopressin is vasoactive drug used for management of hypotension. Most commonly used to treat most commonly used to treat bleeding esophageal varices. Narrows blood vessels, controls bleeding. Endoscopy must be offered to unstable patients with severe acute upper GI bleeding immediately after resuscitation. Similarly, offered to all other patients with upper GI bleeding within 24 hours of admission. Another thing here is endoscopic band ligation. Endoscopic band ligation and sinks taken, Blakemore tube insertion are both used for esophageal varices. Not gastric ulcer. Another important thing here is endoscopy must be done in unstable patients with severe acute upper GI bleeding immediately after resuscitation and in all other patients with upper GI bleed within 24 hours of admission. Now, while proton pump inhibitors certainly play an important role in the management of gastric ulcer, NICE guidelines advise that acid suppression, including H2 receptor antagonists, must not be prescribed to patients with a suspected non-varicose upper GI bleed prior to endoscopy. So, although proton pump inhibitors are having important role in management of gastric ulcers. Still, nice guidelines advise that acid suppression acid suppression must not be prescribed to patients with suspected non-variceal upper GI bleeding prior to endoscopy. Two scoring systems are Blatchford score at first presentation, Rockall score after endoscopy. So these are the important things which we have to keep in mind regarding hematemesis and hemodynamic stability of the patient. So here the patient's complaint of hematemesis is most likely linked to a long-term use of NSAIDs used in the management of rheumatoid arthritis. These NSAIDs, they have tendency to cause gastric ulceration and which may further lead to erosion of a blood vessel. The patient is hemodynamically compromised. She is hypotensive and tachycardic. Therefore, priority in such a case is to bring about hemodynamic stability. The immediate or next appropriate step in managing this patient would be to obtain IV access via two large bore IV cannulas and start the patient on IV fluids. Meanwhile, blood grouping and cross matching must be performed. If the patient is deteriorating further while giving IV fluids, then O negative blood can be administered. Provided that this patient is most likely having a gastric ulcer, terlipressin, which is a drug more commonly indicated in the case of esophageal varices, would be less favorable of the option. Along with that, endoscopic band ligation is used in ligation of varices, would not be useful in gastric ulceration. Sangstick Blakemore tube, which is also used for uncontrolled variceal bleeding, is also not useful here. So, important thing about endoscopy in such cases is that endoscopy must be offered to unstable patients with severe acute upper GI bleed immediately after resuscitation. Whereas it must be similarly offered to all the other patients who are stable and others with upper GI bleed within 24 hours of admission. So in unstable patients with unstable patients, so endoscopy should be done in case of unstable patients with severe acute upper GI bleed. Endoscopy must be done immediately after resuscitation, whereas for all the other patients, it should be done within 24 hours of admission in all the other patients with upper GI bleed. So another thing is, although proton pump inhibitors play an important role in the management of gastric ulcers, but NICE guidelines advise that acid suppression must not be prescribed to patients with a suspected non-varicose upper GI bleed prior to endoscopy. First, we have to do endoscopy, then only we can prescribe proton pump inhibitors. Although these are having important role in the management of gastric ulcers, but NICE guidelines advise that acid suppression, including H2 receptor antagonists, these acid suppression must not be prescribed to a patient with suspected non-varicose upper GI bleed prior to endoscopy. Now, the two scoring systems which are important in such scenarios are Blatchford score at first presentation and Rockall score after endoscopy. Two scoring systems useful in such scenarios are Blatchford score at first presentation and Rockall score after endoscopy. Blatchford score at first presentation and Rockall score after endoscopy. Okay, so now let's move further. A 38-year-old man has worsening abdominal distension over the past year. He has a history of alcohol abuse. His recent blood test shows bilirubin 80, ALT 295, ALP 305, GGT 210, albumin 21, amylase 110. Spider nevi are noted on his trunk. Paracentesis shows clear fluid with 60 units per liter of amylase. He has temperature of 37.1, pulse 85, blood pressure 130/85, respiratory rate 21. Single most appropriate medication to start with in this case. So, edema and fluid overload in third spaces such as ascites are managed with diuretics. Diuretics most useful in cirrhosis is spironolactone. This is because cirrhotics have intravascular volume depletion, which results in high aldosterone state, and spironolactone is an aldosterone antagonist. So if liver cirrhosis is there along with the ascites, then spironolactone is the most useful diuretic in this case. If fever is present, then investigate ascitic fluid aspirate analysis should be done. If high neutrophil is there in aspirate, then we have to give IV antibiotics. Common indications of spironolactone are ascites, patients with cirrhosis developing secondary hyperaldosteronism, hypertension used as one of the last treatment options in step 4, heart failure, and nephrotic syndrome. Amylase levels in ascitic fluid that are around 50% of serum amylase is considered normal, and the ascites is thought to be of non-pancreatic origin. If there was significant elevation of amylase levels in ascitic fluid that is more than 7 times higher than serum concentration, it would suggest pancreatitis. Now let's take a break for a while and I'll be back.